There are 5 neuropsychiatric symptoms that I'm going to discuss in a moment. First is depression. This affects around a third of stroke survivors at some point post-stroke. It tends to have a relapsing and remitting course. Anxiety is also very common, affecting about 25% of people. And again, that often occurs after a stroke. There are different types of anxiety, including phobic anxiety, agoraphobia, and generalised anxiety. So when one thinks about anxiety, it's important to think about the subtype of anxiety. Another important neuropsychiatric problem is post-stroke emotional lability, also known as emotionalism. These are uncontrolled outbursts of laughing or crying and can be quite distressing. The incidence is said to be around 20%, but certainly in my clinical practice it seems to be somewhat lower than that. Apathy is also very common after stroke, affecting about 30% of people in some estimates. It seems to be associated with specific problems on brain imaging such as white matter disease and small vessel disease. And unlike the other symptoms, it's associated with cognitive impairment. The final one I'd like to discuss is post-stroke fatigue. Some people might argue this isn't actually neuropsychiatric in that it doesn't originate from the brain, but fatigue is an overwhelming feeling of exhaustion which is not made better by rest. It affects about 50% of people. For some people it does get better over time. Perhaps about a third of people experience a spontaneous remission in fatigue. But for many people it's a long-standing problem that interferes with daily activities. So the frequency of depression is higher than in the general population. It's generally said about 1 in 5 people will develop depression during their lifetime, so the frequency after stroke is higher than that. Similarly for anxiety, after stroke it's higher than the general population. Also, importantly, the type of anxiety that we see is perhaps different from the patterns in the general population. So some stroke survivors experience a very profound fear of recurrent stroke, which one obviously does not see in the general population. So the characteristics are different as well. For apathy, we do see apathy in older people with dementia, for example, and cognitive impairment. I'm not aware of any really good studies that have compared the prevalence of apathy in stroke, dementia and cognitive impairment, but certainly the prevalence of apathy after stroke is higher than in the general healthy population. For post-stroke emotionalism, we sometimes see similar emotional ability in people with traumatic brain injury, for example, but in the normal healthy population we don't see emotional ability. And finally, fatigue. Fatigue is certainly more common after stroke, and the type of fatigue that stroke survivors describe is very pervasive, very severe, and much worse than anything they'd experienced prior to stroke. So although fatigue is a common symptom that we're all aware of, everybody has fatigue at times, it's different in nature from the fatigue that stroke survivors describe. I think it's fair to say that all of the neuropsychiatric symptoms that I've described affect quality of life adversely. They affect ability to reintegrate into the community, and they affect return to work. Some of them have very specific effects. So anxiety, for example, people may describe a fear of going back to the situation that they were in when they had the stroke. So, for example, if they were in the shower when they had the stroke, they would describe a fear of showering again. For people with emotional ability, the emotional outbursts are often uncontrolled and occur spontaneously, and so social interaction becomes very difficult and people may become very embarrassed and withdrawn because of that. In terms of whether they affect life expectancy, I think that's difficult to say because there's so many confounding factors that influence the relationship between these symptoms and long-term outcome after stroke, although there's been one or two small studies that have suggested that fatigue can negatively influence long-term survival, although that's only a very small effect. But the main effect of all of these is a profound impact on the people's quality of life and their ability to reintegrate into the community and return to work. I think there are three main barriers. Firstly, the time at which these symptoms occur is variable. So for depression, it may not occur until people have returned home. Anxiety may not become obvious until people realise what impact their stroke is having. So understanding when to look for these symptoms is not always clear-cut. That's the first thing. Secondly, if you look at screening on a busy acute stroke unit, the focus is on delivering hyperacute care, on ensuring that people take appropriate secondary prevention, that the necessary investigations are done, and that the focus on rehabilitation is often about looking at what impairments people have, so whether that's aphasia, hemiparesis, and focusing on improving those so that people can be discharged. Adding in screening for those conditions would require time. I think the third barrier is that we don't yet have really good data on the best way to screen for these conditions. There are lots of different screening tools we can use, but we need more work on identifying which is the quickest, most sensitive and specific tool for each of these problems. For people with depression, there's a higher risk with increasing disability, not surprisingly. For anxiety, the data are not very clear-cut, but potentially it's more common in younger people. For apathy, there are definite links with the brain imaging findings, so white matter disease, for example, is something that one could potentially look for as a risk factor. For post-stroke emotionalism, there is very little data on that, and one can't really draw any firm conclusions about risk factors. For post-stroke fatigue, though, there is more information. So certainly if somebody's had fatigue before their stroke, that's a risk factor for developing post-stroke fatigue. Also, there are clear associations between fatigue and anxiety and depression. So if somebody's got anxiety and depression, they may well have fatigue. That's obviously complicated because fatigue is also a symptom of depression on some of the scoring systems. So the relationships are complex. Some studies have suggested it's more common in women than men, and in younger people than older people, but those associations are less clear-cut. Also, we know that fatigue is associated with being less physically active early after stroke, so that's another important risk factor to look for, and is an argument for trying to ensure that people are as active as possible in the early days after stroke.